So welcome back, everybody. We'd like to welcome Dr. Vivek Sharma as our next presenter. Vivek is the director of ZenWaves Clinic. He uses QEEG-guided neurofeedback training with clients who've experienced developmental trauma and other complex presentations. Recently, he was part of a pilot program studying the utility of QEEG-guided neurofeedback in early psychosis and developmental trauma. And this was in collaboration with the Headspace Early Psychosis program in the Penrith area. Today, Vivek will share with us a discussion of his findings from this program. So thank you and welcome, Vivek.
Thanks, Christy, and thanks, everyone. Let me try and share my slides. How do I do that? Share screen or PowerPoint? Okay. There you go. Okay. So can you see my PowerPoint clearly?
Yes.
Okay, thank you. Yeah, so hi, it's, thanks again. Yeah, so I think Christy was also, she was also part of that same study. So, yeah, so the study actually lasted, it was a pilot study, it lasted nearly a year, or just over a year, from August 2020 to October 2021. And the aim was to study the additional sort of add-on QEEG-guided neurofeedback on top of other interventions which are provided by Headspace Early Psychosis, including psychosocial recovery, medication, and all that. And also the aim was to study the effect of childhood trauma incidents and its various relationship with the presentations and treatment and the such. So we actually ended up using MACE questionnaire. So we were able to recruit 18 young persons, out of which 5 were underage, under 16, and were not able to consent for themselves. So 13 was the final number. There were differences in diagnosis of these young people. Many of them were on medication, and the number of neurofeedback sessions that we could provide also was quite variable. So some of the older participants received around 40 or more. Some of the sort of more recent ones received less. So so there was that issue. And even after dividing the sample in first episode psychosis and UHR, which is ultra high risk state, the sample size just wasn't really enough. So the funding actually ran out. The project could not continue, but there are many success stories from this project, and I'm happy to share some of them here today. So this is my standard slide. So just, I know everyone is aware of what neurofeedback is, basically brain biofeedback. So just giving the brain a snapshot of what it is doing in real time enables the individual to change that activity. And that helps to change the baseline state of the brain, and over a period of time, repetition and all can somehow change the brain's functioning, for instance, neuroplasticity, and that is the basic mechanism. In terms of just a brief touching on the history, so neurofeedback has actually come a long way since the time there were standard protocols, so fixed protocols for conditions like ADHD, when Sturman, Lubar, and these guys started out with neurofeedback. But nowadays we have more tailor-made protocols, which include different rhythms, regions, networks to work with different conditions. So more and more neuropsychiatric conditions are coming under the purview of neurofeedback. Many published studies exist in various conditions. Trend is towards QEEG-guided neurofeedback therapy. So it's guided by quantitative EEG, but a phenotype model is also a guiding force, which tells us that there are EEG patterns which exist, which are independent of the QEEG sort of normative database, etc. So these are two baseline sort of, let's say, principles that we also use in our study. So this is what a QEEG is basically. I think everyone knows what QEEG is, but just rehashing. So it's just an organization of brain in terms of different rhythms, which all underlie different neuropsychological function. So, for example, data is something which you will normally find in sleep, and also if there is more data in eyes open, you can, if it's localized, then brain injury could be considered. Similarly, theta, alpha is something that you see in a very relaxed individual, but if it's too much, then you also start wondering whether the individual is dissociated. We see in post-traumatic stress disorder. So all these rhythms have a meaning in the brain. So it's important to know that because then only you can target them wisely with neurofeedback, and also they are very helpful in understanding of QEEG-guided medications, which I use a lot. So and having understanding of these definitely helps. So yeah, so quantitative EEG can help you quantify these brain rhythms, compare and so on and so forth. So all different measures have different meaning. Absolute power, relative power, asymmetry, which is quite a known concept, coherence, and all those things have some certain meaning which can be used very powerfully. There's just an example of changes that we found in our clients. So I actually look at these things very, very closely. What's happening in the baseline QEEG in terms of comparison to norm, and then what's happening after 20 session or say 40 session. And I am guided by that. In addition to the symptoms improvement, of course, not in every case you can have changes. And I'll show you those cases as well. So where we found changes and we could not find any changes, and what could be the reason? Because there are people who say that we are treating a brain, we're not treating a QEEG. So there's no reason in tracking changes via doing repeat QEEG, whereas other people, do that more as a as a way of doing things. So in this, for example, the theta, relative theta, has obviously disappeared in 20 session. And we also saw that changes in individuals' mood, focus, motivation, attention, which improved. So that is basically what what is the function of theta. But the beta hasn't changed. So obviously, we need more sessions for that. So that's how you can track. You can have a strategy. So there is something about research and neurofeedback. There's enough research on neurofeedback. The number of studies. A lot of people insist on randomized controlled trial, which is definitely not possible. It's difficult to do in neurofeedback. It's a different sort of ball game. So I always like to talk about this, and especially this quotation that if you judge a fish by its ability to climb a tree, you will always be misguided, because the fish cannot obviously climb a tree. So you'll have to find different ways of finding the utility of in different ways rather than randomized controlled trial. There are many studies, at least in the top two. There are meta-analysis available, which are for everyone to see, and the different brain neuropsychiatric conditions where more and more sort of evidence is there in terms of well-controlled studies, comparison, and maybe not randomized, but they exist. This is just a paper which was published recently, where they basically said that neurofeedback is definitely feasible. It leads to measurable changes in the brain. Larger studies are required, and sustainable changes are seen in neurofeedback. So just taking a snapshot of this more recent review, especially in schizophrenia. And all those studies that were included, unfortunately, they all had a very small number of sessions, and some of them were different methodology we use, fMRI and EEG, and different methodologies we use. So it's difficult to really compare those studies. But even in the end, they said that it's definitely something to look forward to. So having said that, let's talk about some of the cases that I saw. So this is 27-year-old female. She was living with her partner at the time. She was pursuing a bachelor's degree. She was on clozapine 100 milligrams because she'd been diagnosed with treatment-resistant schizophrenia. She used to think that people can read her thoughts, see her imagination. She used to say telepathy is real, everyone is involved. Symbolism, she used to see colors, orange, anyone wearing color orange or a car of orange color would mean that she was going to die. So that was the message for her. and she'll have these strange thoughts popping in her head, and about her family. So she'll see her family member and have a thought, die, be, bitch, or something like that. So she'll have these very distressing thoughts. She used to have interfered with her ability to engage with the family, go out, do shopping. So her independence was absolutely impacted because of these issues. She had few admissions. First in 2016 with substance-induced psychosis that lasted for 3 months, where she reported she was being watched, hearing voices, diagnosed first with psychosis. Then in 2017, where she was there for 2 months, referred to Headspace, tried on a number of medication. 2019, she had 2 admissions with suicidal crisis, and that's when she was diagnosed with treatment of schizophrenia. She was started in clozapine 300 milligram, but she could not tolerate because of the weight gain and side effects. So that she reduced to 100 milligram, refused to take no further. She reported some symptoms around OCD at age 7, so such as going around the bed a certain number of times, some certain superstitions, and also anorexia at age 12, and I think bulimia, which in teenage years. She was abused physically and emotionally by her maternal grandmother, who used to lock her in the room. Her parents also separated at the same time. So those things were there in the past. There was family history of psychiatric problems, and some scales, which was part of standard sort of monitoring in Headspace were there. Y-box were moderately severe at 27. So her EEG at baseline actually showed epileptiform transient, and we got a neurology consultation to basically understand what should we do, how do we proceed with this. And they said that it's very common, these kind of transients are common in clozapine. Don't really worry about them. They actually associated with better prognosis. Now, we don't know because there are 2 theories or 2 sort of opinions about these epileptiform transients. Many people have them as a part of developmental syndrome. We people who have got ADHD, autism spectrum disorder, have these transient. I've seen many of them. To me, they suggest a degree of brain dysregulation, but for neurologists, especially if someone is on clozapine, they just take it as something that is always there. You don't really worry about that. So anyway, we went with that, and this is her rest of the EEG. So that was the first one was eyes closed, I think, and that's so this is eyes closed EEG. This is eyes open. You can see the fast wave frontally, and then you start thinking of anxiety, OCD, those kind of things, just by looking at the raw EEG. So this is the eyes open topograph, and you can see the fast wave in pretty much everywhere, frontally, temporally, and there's a bit of theta in the midline, which you can see. And you can also see that in the comparison with the 2 standard deviations. It's quite significant, both in the theta and in the beta and high beta range. We did a Loretta to understand what's happening. So basically it told us something is coming at F3. So this is all the fast waves. So F3, F4 are definitely involved. Then I think T3 and T4 also showed up as areas of concern or areas of where some activity is happening, especially the fast wave. So we started in first 10 sessions. The gist was she is reported feeling calm, which lasted 4 to 5 hours, feeling good, more organized. Then 11 to 20 sessions, sleep was improving. She was able to control her obsessive thoughts, less paranoid, improved communication. So sleep, she was actually very happy with this improved communication because she was very particular about what she was saying, and clarity of speech and communication was very important. So she thought she was very fluent. She actually used those words. I don't know how. Socialization was improving, self-control. She was earlier using alcohol almost every day just to be able to sleep in the night because her system was so hyper activated, overactivated. But that requirement came down drastically. In the past, although she was not using any illicit drugs while she was in Headspace, but there were times when she had the urge to use with her boyfriend who was using them. but that also gradually subsided. So he was not inclined to use them. And she said that she's feeling more empathic. So that was her comment. Then further, she said that her OCD is improved and is maintained, and she's not reacting to these thoughts. So probably she must be talking about those intrusive thoughts, words that were coming, where she was having these abuses coming in a head, and she was reacting by not going out or not interacting with those people. So she was not really doing that as much. And also, she said that she had more improvement with neurofeedback than with medication. So that was good to know. She was able to relax. She said she did not need to drink. She was not putting random meanings, random thoughts. So basically, she was not having too many referential ideas, because that's what you do when you see something, you start thinking about, you start making a theory about those things. So some of the referential stuff, psychotic stuff was coming down. Then she was able to relax as we went further. She said that she still has thoughts, but more ideational level. She's not acting on them. Her time management improved, concentration, writing skills, and reading skills improved. Overall, things have improved 300%. I don't know how that is possible, but that's what she said. So she was really, really happy with how she was progressing. And this is what she said when she left, when she finished this program. So since I've started neurofeedback, I find that it's been best help that I've received since the onset of my psychosis for a number of years. One of my main issues was being paranoid around people. It's immensely helped in that regard. I do not have to fight with my thoughts anymore. For example, when I'm out shopping and around the crowd, I would be otherwise in a flight or fight mode and run away. But now I'm more accepting of them, of it, and more control of my thoughts. I still get delusional, paranoid thoughts whenever, however, I do not fight with them anymore. I'm able to accept them. Anxiety levels have decreased greatly since beginning. Racing thoughts, which was a major issue in my psychosis, have decreased. Another factor neurofeedback has helped me is with my university, and it's helped me be more concentrated, focused, organized. It's been incredibly helpful with my speech, allowing me to be clearer and understand, comprehend what others are saying to me. Neurofeedback has been effective in reducing my medication. I can feel more improvements in my brain. So she was also given a sertraline. I think when she was discharged from the neurofeedback and ultimately from Headspace, she was on, I think, 25 milligrams of sertraline along with the clozapine, which was also reduced to, I think, 50 milligrams. She would not take anything more than 50 of clozapine. Which is a very minimal dose, but that's what she liked, and she was happy with that. And many of those things suggest that what she was dealing with was a lot of anxiety, which was actually masquerading as her psychosis. So sometimes when people have psychosis, it's difficult to know whether you're dealing with a extremely anxious individual or obsessive or OCD kind of syndrome, or this is a psychosis. Sometimes so much mixed. So it makes sense to look at and address all those concerns. Of course, I'm not saying you start doing pharmacy or give them everything, every medication possible. But this is what neurofeedback can do. People who are really, really complex, who otherwise will feel that they require every known medication just to calm their brain down, it reduces that urge, sort of feeling. It can regulate the brain in so many ways. So that was good. So this is her brain map on baseline. So topography at the baseline, and you can see that those things that you already discussed before, and the fast, excess of fast beta, and both in absolute and relative power, and excess of theta. And at 20 session mark, there's a change because all that fast wave on temporal regions has come down. The theta is gone, and this has also come down. And you can see these peaks, all these peaks are gone. And now even those peaks in the front have also come down. So you can clearly see those changes happening in the brain. So she was an excellent case of improvement, not only in symptoms, but also in the brain map. So that's case one. Now, this is a different individual. So she was a case of Headspace, not part of the study, by the way, but she was discharged from Headspace only recently when I was referred to me, and she was with the Headspace for a full 5-year program, and she was with them for like so she was a 27-year-old female who was working part time, and she had all sorts of hallucinations, visual, tactile, taste, auditory hallucination. She was discharged with rapid cycling bipolar disorder and auditory hallucination. She was on amisulpride because other medication did not help. Seroquel, which is antipsychotic, lithium. She had done neuroimaging done in twice, MRI, and there was nothing there. In terms of her developmental history, she did have she was born premature with jaundice. She was abused by her brother. She was abducted. I didn't go into too much details, but it was enough to know, for me to know that she had a hard time. She started having a hallucination when she was 14, migraines with visual auras, then head injury in a car accident. Then she collapsed on a train station. No one knows what actually happened. She just fell down. However, there was no seizure. There was nothing neurologists could find in her brain. And in 2017, she had bipolar disorder was diagnosed. So in terms of psychopathology, she would say that there is these voices, one internal voice, another male voice, which probably is outside voice, which mocks the internal voice. So I never got into the details of what is the dynamic of these voices, but that's what it described. And visual hallucinations, she would see someone dressed as Abraham Lincoln crossing the middle of the street when she was driving. So that used to happen very often, and that was scary enough. And she used to see when all those things when she was more depressed. She also reported a taste of glass in her food, a random sort of taste in her food, and also skin being touched and insects crawling and that kind of stuff. She also reported that when she looked in the mirror, she would not recognize the person in the mirror because she didn't know. So she was quite dissociated. And when she moved towards something, she had no awareness of moving. So that was what she described. There was some family history in dad, bipolar in brother, and DSD. Medications were tricky because lamotrigine and fluoxetine actually made her manic. Sertraline gave her hallucination. Lithium was okay. Amisulpride was good, which was she was put on, but she did not have any menstrual periods, so she stopped having periods. So we did twice weekly neurofeedback, and on third session, she said she had not had hallucination for a whole week, which is amazing. The last 5 or 6 years, she's never had a period of week where she did not have any hallucination. So it's what quite early improvement in her major symptoms. And she said that all the hallucinations have completely dampened. She's feeling more alert, concentration is better, feeling clear in her head. Then she reported feeling stable, no return of psychotic or manic symptoms, better concentration, focus. The psychiatrist was happy to reduce, sorry, this is not, there was some Seroquel. She was also on Seroquel to reduce that. And overall, it was good because then her menstrual period actually returned. So she was on a cocktail of antipsychotics, and antipsychotics can cause amenorrhea in females, many times, whatever. So that was good. Then as we moved on, she said that things have improved by 80% since beginning neurofeedback, so around 20-25 session mark. But unfortunately, she got hit by a truck around 25th session, and that took back some of the sort of things, improvement that we had. She started having anxiety, low mood, but did not have any manic symptoms. And she had the migraine re-emerge, but it settled by another 4 sessions. That was fairly quick. Within 2 weeks, she was as of back to normal. And she commented that her depression used to last for months, at least a month, but now it's only 2 days. So she would report that she's feeling low on neurofeedback, and then when she came next time after 3 days, she said my mood is okay. Whereas before she was feeling suicidal and self-harm and urges, and was on the verge of checking into hospital. But when she came back, she said it didn't last very long. So that was good. And at that time, she received 1 session of EMDR, But that didn't go well, probably because the trauma and stress, which is all sort of happened very fairly recently, and she actually had a panic attack and dissociated, and then required another 4 sessions to settle her back. But with neurofeedback, she did settle very fairly quickly. I think majority of the time she had T3, T4 as her preferred sort of placements. So by the end, she did not have any hypomanic symptoms, no migraine, anxiety was manageable. We will talk about boyfriends, which I don't talk, but that suggests to me that now she has moved on to more real life concerns rather than the psychotic and stuff and migraines and psychopathology. So that was another good outcome in this case. Now with her brain map, so this is the initial brain map, and we can see that there is an axis of theta. He is almost everywhere, but that could be because of the medications. She wants amisulpride and lithium and all those psychotropic and mood stabilizer. They cause increase in theta levels, and you can see that here. And after I think 20 sessions, she still had that. So not in every case you will have changes in the brain map of QEEG. And we see that this happened in this case. So there wasn't much change, but the symptoms had definitely improved. So we can just only put down this as a side effect of medication. And so there was no really change in this regard, at least. But otherwise, she was much more functional, much more symptom free. Okay, so then the third case is another interesting female part of the study, actually, 21-year-old female. She had multiple diagnoses, borderline, ADHD, migraine, OCD. She was very sensitive to noises, heat. She was given dexamphetamine in the past for ADHD, which helped. Had an extensive family history of psychiatric problems. She had some blood clotting issues, factor V deficiency, and vertigo, and had a degree of developmental trauma, parental separation, sexual abuse. Housing was a big issue. She was not living with anyone. Her own. She was living with her grandfather, which was again a very conflict-ridden. It was a very difficult sort of living situation. So, and this is her baseline EEG. So you can see there's a lot of fast wave happening in certain areas involved more than the others. And she was not taking any benzodiazepine. So it's a genuine fast wave that we see in frontal and temporal regions. And that's her quantitative EEG. You can see there's a different fast wave with right side, less on the left, but it's definitely there. And that can be seen in the normative comparison as well, both in the beta and the high beta and absolute and relative power maps. So when we started initial first 10 sessions, she reported poor sleep initially. She was sleeping 3 hours on average. Mood swings were extensive, self-harm. She was very snappy. She was actually diagnosed with bipolar disorder. And lamotrigine was considered based on the diagnosis and also the fast wave in her brain in EEG, but she refused to take because she had issues with the medication in the past. However, with neurofeedback alone, impulsivity calm, less obsessive counting, less intrusive thoughts. She used to have these thoughts of stabbing herself and punching in the wall, and very disturbed. So that calmed down fairly quickly. Sleep actually improved, so that was good. Then later on, I think she had some stress induced by housing. So her grandfather the housing would not allow her to live with her grandfather, and her own housing apartment was not suitable for many reasons. I forgot what, but she was in a very conflicted situation with grandfather who was not very welcoming and very abusive, and housing which would not would allow her to live with her grandfather. But anyway, that caused a lot of stress for her, and she had that expressed in visual and auditory hallucinations and experiences. And also the psychiatrist did not agree with the bipolar diagnosis, so there was a stress from many sides. So that continued. Her situation worsened. She started having clear hypomanic episodes, singing, dancing, everything. Eventually, lamotrigine was commenced, but she would not take it. Gradually, I think she started taking the medication, the hypomania settled, less auditory hallucination. Then she got diagnosed with rheumatoid arthritis, sleep apnea, and then COVID happened. That again stressed the situation. Then on top of that, methotrexate was started by the rheumatologist. All this combined to cause another episode of hypomania, where she was overspending, she was talking to demons and gods, and at the same time, she's coming for neurofeedback. So she was not like, except for the period of time where she was in hospital for 1 month. So that happened. But when she came back and started neurofeedback, she started settling down. We did a genetic testing for her, which found that she had this MTHFR gene, a particular gene which causes issues with methylation of folate. So, so instead of folic acid, L-methylfolate was supplemented, and also dexamphetamine, which someone had started for her her ADHD symptoms. She really liked dexamphetamine for some reason, but that also had to be ceased. Methotrexate was changed to hydrochloroquine, and that led to a lot of improvement. So although she had a flare of rheumatoid arthritis, but it subsided after hydrochloroquine was instituted. Her sleep improved, her hypomanic symptoms settled down, and she did not have hypomanic symptoms. She still has a little bit of mood fluctuations, but nowhere close to what she had before. She stopped doing neurofeedback now, but she's continuing with the psychiatric consultation. I think she's doing much better. So moving on to the final case. So this is an 15-year-old who lived on to 16, and a gentleman. I'm not sure which country he came from as an immigrant, but he was very, very tall. He's extremely tall. So he's 6'2", 3", and can be very, very imposing, very, very sort of scary. So he was living with his parents and 5 siblings. He was referred to Headspace after he was diagnosed with psychosis. He was on dexamphetamine, aripiprazole, propranolol, I think from the GP. And the psychopathologies were that he used to report voices, hearing something, and could not sleep in the nighttime. But he did not tell what exactly he's hearing, who he's hearing. He was continuously, he kept laughing inappropriately, pacing, and would not change his clothes for weeks. Use the same socks. So it was difficult just to live with him. A lot of questioning, asking same question over and over, hand washing, hoarding. Fairly severe OCD was diagnosed, and is also very hyperactive. Had autism, he's been diagnosed with autism, and had a lot of tics. He had almost everything. He was defiant. He was violent towards family members. He had a very high risk, in terms of being kicked out from school. He was initially involved with mental health at a very young age. Then stimulants were prescribed, but that caused side effects. He stopped eating, lost body weight. Second pediatrician said that he doesn't require medication, just let him play some sport. Then I think in 2019, he became violent towards mom. He was suspended. Then medication was prescribed, but then he refused it. Actually, police were called many times just to administer the medication. So NDIS support, he was applied to NDIS, but then he was violent towards the carers. So the carers used to come and give him medication. The family could not. And he used to kick them and beat them. Yeah, so there was really, really difficult situation. On the EEG, we did a fair few EEGs for him, and you can see this epileptiform discharge. And by this time, we were seeing epileptiform discharges in many of the clients. So we actually stopped sending to neurologists because we were taking ages for anyone to see them. And they were not really diagnosing them with epilepsy because there was no clinical history. So it was just a pointless exercise, really. And we saw that in the initial EEG and the 20 mark EEG, but I think later on 50 mark EEG, it disappeared, partly because of the medication. But we saw that, and we see that in a lot of clients. And we actually see that focus is in the F4 area, right frontal area. So that tells us something, that probably some issue around mood dysregulation could be a result of just what we are seeing here. Then in the sleep EEG, they see hypercoherent alpha and again more epileptic discharges. So when we started neurofeedback, his self-care improved initially, and they started showering at times, changing clothes, aggression better, but repetition continued. Still talk about police going to jail, people going to die, and said random threatening things. Headspace had actually is considered guardianship for out-of-home placement. Things are so bad. Then, as we progress further, his with neurofeedback, sleep improved. He was waking up on time. Some of the issues were still there. Medication were adjusted. So stimulants dose were reduced because of epilepsy. Epileptic discharges, sorry, not epilepsy. Right frontal calming was added because of aggression. That improved a lot. So something around F4 theta training actually helped. So he improved at school, less defined, less talking in class, and generally much better. There was one episode of aggression when mom tries to change his socks. So hoarding was a major concern at this stage. But other than that, things were improving. He was compliant. His behavior was better. Some quetiapine was added because he was had the issue side effects with aripiprazole. So aripiprazole can be very, very activating for individuals who are sensitive to medication, and he probably one of them. Anti-epileptic like lamotrigine was considered because of the epileptic discharge. And one time he said that he vacuumed his room for the first time. The parents were really happy. So that happened around 30-35 session mark. And physical aggression came down. Laughing and pacing was still there. Sertraline was added because the hypercoherent frontal alpha and OC symptoms at this stage. So we basically, changed the whole treatment regime gradually, looking at what the EEG was telling us and what the behavior was telling us. Then around 40 session, he stopped collecting rubbish. Things improved. He would start helping his mother with certain things, cleaning his bathroom. Supplement inositol was added, but there was some defiance, at times. Finally, the pediatrician agreed to stop dexamfetamine, and the family agreed to it. And that was, I think, the major thing, because after then, a lot of spacing, talking, repetition that came down. Less aggression. So last I heard, I think he's done around 74 sessions. There's no aggression, no police involvement. He's still living with his home. There's no one thinking about guardianship anymore. So I think he can stay with the family a little bit more longer. And we don't know how things will turn out, but they actually turn out very well for this individual. So alpha hypercoherence at baseline was around 0.8 for 9 to 10, 11 to 12, which came down to 0.4, which is okay. So one of the measure of seeing how the brain is effective in terms of its functioning. So that was one good thing. Although the QEEG did not change much in terms of absolute and relative power maps. So the lessons in case 1, we saw anxiety masquerading as psychosis. But regardless, neurofeedback of the actual diagnosis, neurofeedback actually helped. Case 2, we saw developmental trauma, which probably triggered a major psychosis and fairly complex psychopathology in that lady. But we saw the neurofeedback actually modify the expression of bipolar, that she was having shorter bipolar episodes. Then in case 3, we saw some of the medication in this lady, stimulants, steroid, methotrexate in context of rheumatoid arthritis, actually triggered her or dysregulated her brain. Along with ongoing trauma, not just historical, ongoing trauma can also dysregulate. But and the question is does developmental trauma underlie this increased vulnerability for stress and medication? So that is something that we would like to find out in the future. And then finally, ADHD or clients with complex sort of childhood conditions, ADHD, autism with epileptic transients, they're very sensitive. So they may not be able to tolerate stimulants, have all sorts of side effects, not just loss of appetite, aggression and the whole lot. So better to give them lamotrigine and quetiapine, because again, they can be sensitive to EPS, extrapyramidal side effects or other antipsychotics. However, extensive neurofeedback can change the trajectory of these complex childhood presentation. And finally, the question that we have is, how does developmental trauma interfere with early psychosis or trajectory of early psychosis or developmental conditions? And are there any shared biomarkers? Well, I know there's one. So low alpha, baseline alpha, and low alpha response is something that we see in people who got ADHD, a subtype of ADHD, and also people who have trauma, PTSD. So there is a lot of shared biomarkers. So the question is, can we do something with the neurofeedback to change the expression of both the psychiatric condition and the effects of developmental trauma? So this is the final slide. So there's a study done recently which showed that developmental trauma predicted psychopathology at 18 years of age. And for complex presentations, you require good psychotherapy skills, psychiatric medication, in addition to neurofeedback. Sometimes even with neurofeedback, you'll find that you need something more. So I think some of the other previous speakers have also talked about using neurofeedback along with other sort of modalities, which is an excellent strategy. Psychotherapy. So I think that finishes my presentation.
Thank you so much, Vivek. I really appreciated hearing about those case studies. I've only had one experience with a schizophrenic and I found it extremely stressful, and it was very encouraging to see the results that you have achieved. Does anyone have any questions? We have a few minutes.
Yes, I have a question. Can you hear me?
Yeah.
Yes.
Okay. Could you be a tiny bit specific about the protocols you were training? Because the lecture was about QEEG-guided neurofeedback. So could you tell us about the QEEG-guided neurofeedback in those cases?
Yes, so it would have been very difficult to include all the protocols, but I think generally speaking, where we were dealing with primary trauma, so historically, so there was a lot of trauma historically. I think T3, T4 is where we started. And when there was a lot of dysregulation, I think we did F4, T4. And once things improved a little bit, and the issue was mainly around sort of sleep and general bodily restlessness, I think working on sensory motor strip was what we did. And towards the end, I think we did, if needed, some left frontal work. But I don't think I did any left frontal work activation in any of those clients. They were too dysregulated. So I think I stuck to T3, T4, something on the alpha range, low alpha, the high alpha range, depending on what they're tolerating, or F4, T4. Some people who had a lot of frontal alpha, I rather than doing neurofeedback, I just gave them a little bit of SSRI. So I think that's what I mainly did. Does it answer your question?
Yes, thank you.
Anyone else?
Yes, I wanted to ask a question, if that's okay.
Sure.
For people living with psychotic illness, the paranoia and anxiety can sometimes, I imagine, make it quite difficult to tolerate having sensors on their head or any kind of intervention like that. Did you have to deal with that at all?
Yes, I think the first lady who had astigmatism, schizophrenia, it was difficult to get her to come to neurofeedback sessions, because she was on the impression that we will steal her brain's data. She had a lot of thoughts about, telepathy and people stealing her thoughts and all those things. So it was really difficult to explain to her that what we're doing is just measuring, which we do with this QEEG. Fortunate for us, she complied. There were other clients where the family members were sort of involved, and they were shown what is QEEG, how we do that, how it helps with neurofeedback. It's very attractive, it's very lucrative, because it does not require medication or low doses of medication. I think that's where they tilted to the balance in favor of neurofeedback or QEEG, because they don't want medication. As much as they hate their brain to be tampered with, but they don't really want medication, or lower doses. Everyone is unhappy with the side effects. So that was really helpful. And once they did one session, I think first session, if you do something really calming, then the second time is much easier. They'll come back. Yeah. So,
Thank you. Darius?
Yes, thank you, Vivek. I just wondered, looking at those cues, if you thought at all about thalamocortical dysrhythmia in the presentations.
Yes. Generally speaking, that is what we are seeing. Yeah, but when you look at the epileptic transients, something else is happening. So I think my approach was yeah.
So there's ion channel issues in both thalamocortical and epileptiform activity. Can you comment at all about what the treatment implications there might be?
So there are a lot of treatment implications. So for someone with the epileptiform discharges, that means their brain is obviously activated. Something local is happening. Some people had more generalized, but in for example, this individual is something very, very local is coming up. So that told me that could be one area for neurofeedback, and that depends on what frequency that area can tolerate. But I will definitely include that area at some stage during neurofeedback, and that was my strategy always. Another thing is some medication they will not be able to tolerate. So in this case, the individual with ADHD and autism, he had a lot of side effects with stimulants. He also reported a lot of side effects with aripiprazole, which is a novel antipsychotic with partial agonist sort of activity. So anything which has increases dopamine, they cannot tolerate. They'll have a lot of side effects. So that is the implication in terms of. And also, they will probably do a little bit better if you try some anti-epileptic in those cases. Yeah, so both in terms of medication and neurofeedback, that was really helpful.
Thank you very much, everyone, and especially to you, Vivek, for your presentation.
Thank you.